Hello everyone and welcome to this new lecture. Today we'll be talking about pharmacological management of behavior of pediatric patients. And first one of those pharmacological management of behavior methods is called conscious sedation, which is a controlled state of depressed consciousness, so the patient will be unaware of the surrounding, and this way the dentist can work on the patient without many reflexes. Although some protective reflexes will be maintained and consciousness would also be maintained. This procedure also allows the patient to maintain a patent or airway so he can independently breathe and continuously do so. In addition to that consciousness and reflexes and breathing, there is the appropriate response to physical stimulation or verbal commands. Example of verbal commands, like if the dentist tells the patient to open his or her mouth. Some other goals of conscious sedation, other than maintaining the patient's comfort, maintaining the patient's confidence, is to control the inappropriate behavior that could interfere with such procedures. Also to produce a positive psychological attitude toward future treatments or future dental care. This also would be more safe procedure we would have. And of course, the main goal is to treat the patient out of his pain or out of his discomfort with his condition. There is another state and pharmacological management behavior that is different from conscious sedation. It's called deep sedation or general anesthesia. In this case, the patient would lose his protective reflexes and ability to breathe would be also lost. Therefore, the patient would not be able to maintain an open airway without help from the ventilators. We use conscious sedation in some indications, including the patient's inability to maintain an emotional and psychological state during the procedure, or if having a physical or medical congenital disability, if the patient is fearful or anxious. If the patient is fearful and anxious, the procedure is done. Some consideration to be taken in consideration while doing the conscious sedation include the practitioner or the dentist's ability to possess a thorough knowledge and know how to use his agents carefully to administer the sedation. I should be familiar with the sedation methods that are common in this field. Careful planning and documentation should be used with every single new patient, and this is done by carefully examining the behavioral profile of the patient, the type of treatment and its extent, to calculate the risk to benefit ratio, and the ability of the patient's family to meet the expensive and prolonged treatments. Before the procedure, also the patient should be evaluated and examined to see if having an existing medical condition or allergic reaction, as an example for the sedative agents. There should be also documented informed consent from the patient to both the child and his family, and the consultation period and inner review should be done with the family to explain all the risks and benefits and potential hazards associated with conscious sedation. At the time of the procedure, other facilities in the hospital or the dental office should be provided to maintain the comfort and planning for any medical emergency calls or procedures. Now let's talk about the anatomic and physiologic differences between patients. When we prepare the regimen of conscious sedation, it's important to consider the differences between adults and children while applying it. Of course, these differences include age, weight, size, and they are obvious differences, but a less obvious difference include the decreased metabolic rate in adults compared with children. And it is called the basal metabolic activity, and it's of course greater in children, and that will affect both the drug response and physiological parameters as well. When we have a patient that demands greater amount of oxygen with a smaller alveolar system and less mature respiratory system and respiratory rate is far higher in children than in adults, and that's of course very important to be considered when we apply sedation or other drugs that decrease the rate of respiration. And there is a standardized system for evaluating tonsillar size, and that one is called the classification of tonsillar size system. It is considered of 0, 1, 2, 3, 4, and in patients with less than +3, that's okay. 0, 1, 2, that's okay. But if they are more or equal to 3, that's not good, as in 3 and 4, because their tonsils will be covered and they would have difficulty breathing while on sedation, which could lead to obstruction of the airway. And that's why careful dosage should be given, and not all patients have the same response and ability to take a dosage of some kind, and it's neither a calculation of the age only or the size only. We'd have to take all considerations when dealing with any patient. Okay, the procedure here begins with the selection of patient. Then we move to the informed consent. Later we do instructions to the patient. Afterward, patient preparation. Then administration of sedation agents. Later, monitoring of the patient and treatment complete after monitoring of the patient. Last but not least is patient dismissal or patient discharge. Let us start with the patient selection and preparation. In patient selection and preparation, we have to select carefully which patient would benefit from conscious sedation and which one will not. We must not indistinguishedly and indiscriminately choose all patients that going through a preparation. Many profile assessment or many anxiety assessment profiles are developed for the dentist to choose which patient is best selected for the procedure and for conscious sedation. Also, we do physical examination and health examination, and this would help us to choose from many classifications that were made by the American Society of Anesthesiologists. This society have divided the patients into 6 classes, and only patients with class 1, 2, 3, 4 are available, for the 1 being the most routinely acceptable candidate for conscious sedation, and 2 and 3 can also benefit, but unlike number 1 that will benefit the most. Patients with a category of 1 of 3 and 4, as I said, they will benefit, but in this one we would have to provide all the facilities and medical and emergency services around during the procedure. To give you a brief classification of the American Society of Anesthesiologists, they have number 1 or patient number 1 or class 1, that's a normal patient. Class 2, mild systemic disease. Class 3 moderate systemic, 4 severe systemic, 5 that patient that is not expected to survive without the operation, and 6 a brain dead patient whose gone organs are being donated and removed. Again, healthy, mild, moderate, severe, morbid patient without many or high survival rates, and the brain dead patient. Next, let's move on to how to see and examine the physical evaluation. In physical evaluation, we have to see what are the vital signs, including respiration, blood and heart pressure and rates. Evaluation of airway and ASA, American Society for Anesthesiologists, classification is also included in physical evaluation. Instructions that are given to the parents include instructions about eating and drinking, so the patient should not eat or drink anything unless the doctor is advising them to do so. Most importantly, do not drink milk or solid food midnight before the scheduled procedure. Children between 0 years and 3 should be instructed to stop solid food and maintain a diet of clear liquids up to 4 hours before the procedure. Children with 3 to 6 years are instructed with the same instruction only for 6 hours and not 4 hours before the procedure. Patients age 7 and greater should be instructed not to eat or drink except for clear liquids up to 8 hours before the procedure. Now let's move on to some other instructions to the parents. Include change in health. Any change in child's health, especially when a child is developing some kind of a cold, infection, fever, within 7 days before the procedure, the nurse may delay or reschedule the appointment for the procedure in order to maintain and avoid any safety risk to the child. More instructions to the parents includes accompanying the patient to the dental office and remaining there until the procedure is done. Arriving early is preferable. When it comes to medications, it is okay for the child to take his regular doses and medications, including seizure medications and prophylactic antibiotics. Those medications should be prescribed by the child's physician and should not be giving the child any new or other medications before or after treatment without checking first with the dental office. After the procedure is done, only water should be taken then. So sweet drinks are okay next, but in small amounts, repeatedly, instead of large amounts continuously taken. When it comes to the child's temperature, it's okay for the temperature to arise or elevate for the first 24 hours after the treatment procedure. In order to alleviate this condition, acetaminophen for every 4 to 3 hours and fluids are indicated. After the procedure, some other considerations to tell the parents are: if you see your child vomiting persistently for 4 hours or more than 4 hours after the procedure, you would have to seek medical consultations. Or if the temperature of the patient is still above 101 Fahrenheit 24 hours after the procedure. So if it goes above 101 Fahrenheit after the procedure, they should seek medical attention. And if the temperature keeps elevated or stays elevated after 24 hours, they also should seek medical attention. If there is any other concerns for the patient's health and safety, like breathing problems, the parents should seek help. When we start talking about the sedation techniques, we will talk about some medications that are used to how to be administered for the production of a sedative effect. A variety of methods used to alter the patient's or the pediatric patient's mood, and these sedative drugs can be administered by inhalation or by oral methods, rectal, submucosal, transmuscular, or intravenous routes. When we talk about nitrous oxide and oxygen sedation method, about 85% of pediatric dentists use this method for patients' sedation. They use oxygen and nitrous oxide, which will make it the most used method in sedation and the most used agent. Nitrous oxide is a slightly sweet smelling and colorless, plus it is an inert gas. It is compressed as a liquid in cylinders, and when it is released, it is transformed to a vapor. The method and the way that the liquid turns into gas is through an endothermic reaction, causing the cylinder to cool down or even to be cold. This gas is non-inflammable but will support in combustion. Now let's talk about how the drug functions in the body, or how the body reacts to the drug. This is called pharmacokinetics. First of all, nitrous oxide is heavier than air, and it has a very rapid onset and recovery time. Also, it will become saturated in blood within 3 to 5 minutes only following its administration, through dissolving into the blood serum fraction of the blood. Later, it will rapidly be excreted by the lungs when the concentration of this drug is lowered or reversed. Through exhalation, this will happen, but a small amount of the drug can be found and excreted in the intestinal gas. There is a phenomenon called the diffusion hypoxia. Diffusion hypoxia signs and symptoms include headache, nausea, and lethargy. Those might occur as the sedation is reversed and the procedure is terminated. Throughout this procedure, the nitrous oxide goes rapidly and escapes quickly through the alveoli to the point that the presence of oxygen becomes very diluted, causing the ratio of oxygen to carbon dioxide to be disturbed, and a period of hypoxia is created. Fortunately, this phenomena, the diffusion hypoxia, does not occur with healthy patients. Nonetheless, to minimize this effect of the diffusion hypoxia, or to reduce its occurrence even with healthy patients, there should be a period of oxygenation from 3 to 5 minutes after the sedation period is ended, in order to allow for proper nasal hood evacuation of the exhaled gas. So just like when we started the procedure with a 3 to 5 minutes administration period, we end the procedure with a 3 to 5 minutes oxygenation period. After we have talked about the pharmacokinetics, how the body is treating and dealing with the drug, now let's talk about the pharmacodynamics. Here, nitrous oxide deals with the body as it will inhibit or produces central nervous system depression. Nitrous oxide administration is classified with the classification of inhalation general anesthetics. Although that it is classified that way, it produces limited analgesic effect, and thus surgical anesthesia is unlikely produced unless a concentration of anorexia is reached. And this level of sedation or concentration is between 30 to 50% concentration. At this level, from 30 to 50% concentration of sedation, the nitrous oxide will produce a somnolent, relaxed patient who might appear disassociated from the procedure and easily susceptible to suggestions. At a concentration more than 60%, the patient might experience ataxia, discoordination, and giddiness, also an increased insomnia or sleepiness. Therefore, it is not recommended that an administration of a concentration more than 50% is used with dental practice. Nitrous oxide will not cause hypoxemia if it's used alone as a single agent, but a patient who relies significantly on hypoxia-driven ventilation, in whom exposure to high levels of oxygen can cause and result in respiratory depression. Therefore, we do not use nitrous oxide sedation in such patients who rely on hypoxia-driven ventilation. When we combine the nitrous oxide agent with other agents that depress the respiration, the result is that the nitrous oxide will reduce the body's normal response to low oxygen tension. Now, after we have talked about the pharmacokinetics and pharmacodynamics, let's talk about the adverse effects of the nitrous oxide and its toxicity. First of all, nausea and vomiting are the most common adverse effects with nitrous oxide sedation, and this adverse effect increases significantly with the concentration exceeding the 50% concentration levels, with the lengthy procedures also that could cause those problems, and with rapid fluctuations in concentrations, and also with rapid induction and rapid reversal and termination. Other adverse effects and risks is that the nitrous oxide will be entrapped in the gas-filled space in the human body, such as the middle ear and the sinuses and the gastrointestinal tract as well. First of all, with the middle ear pressure that will be increased significantly. Although this increased level is of little significance in patients with normal potency of Eustachian tubes, it can induce pain in patients with acute otitis media. Because of this risk, patients with acute otitis media are contraindicated for the use of nitrous oxide sedation. Other contraindications for the use of nitrous oxide include severe behavioral problems from the patient, emotional illness and uncooperativeness, fear of gas or claustrophobia. Claustrophobia, maxillofacial deformities. That deformity could prevent the application and placement of the nasal hood. Also, nasal obstruction due to infection of the upper respiratory tract, nasal polyp, or obstruction due to deviated septum. Chronic obstructive pulmonary disease, that's another classification and contraindication. Pregnancy is another one, and situations in which high oxygenation is unadvisable or inadvisable, such as patients treating bacteria with bleomycin therapy. Now let's talk about the chronic exposure to nitrous oxide, including recreational abuse, which can produce over time neurotoxicity, impotence, and renal or liver toxicity. Also, this can lead to decrease in fertility, and that increase, as I said before, with the renal or liver toxicity can cause hepatic disease, which was found in dentists that were exposed to high levels of nitrous oxide over the period of 3 hours per week. And this fact causes the dentists in the modern age to reduce the leakage from the open systems as much as possible in the dental office. And also that leads the patient to limit the habit of mouth breathing in patients, as mouth breathing could cause the leakage of nitrous oxide into the dental office, infecting dental and dental practitioners with toxicity of nitrous oxide. Scavenger systems are efficiently used to reduce the amount of nitrous oxide in the air, and the laminar air flow is also favorable and might be considered when constructing a new dental office building. Not only dentists, but also dental practitioners and personnel should be examined periodically for exposure of nitrous oxide that was unscavenged. Now let's talk about equipment. There are several manufacturers producing machines for the safe delivery of oxygen mixed with nitrous oxide in order to be used in the conscious sedation in dental office. These machines are safer to be of the type called continuous flow design, with the flow meters capable of accurate regulations. Also, a fail system or mechanism which provides automatic shutdown if oxygen level below 25% is obtained. This mechanism includes visual and audio alarms. As I said, if oxygen levels fail to be at the 25% oxygenation, and there should be a flush lever that can immediately flush oxygen with 100% oxygen level to be administered. There are two types that those companies of conscious sedation units that are produced. The first one is called intermittent demand flow gaseous delivery system that was made for the patients, which can control the delivery according to his needs and requirements. The second type is the continuous flow, and this one produces continuous flow of oxygen, which is more accurate and safe. Talking about this continuous flow system, it has also two types of continuous flow of nitrous oxygen and oxygen mixture. The first one is portable mobile head, and the second is wall mounted with mobile head. Again, the first one is portable and the second is wall mounted with mobile head. The components now of the continuous flow unit, which has compressed gas cylinder and pressure gauge, reducing valve or called regulator, flow meter, reservoir bag, conducting tubing, and of course nasal hood, full face mask or nasal cannula. Thank you for listening to this conscious sedation lecture, and I hope you understood much more about this procedure.